Okay.
Okay, so hello everybody. Today we're joined with Mark Comerford, Technical Director from Comera Science, and also Ryan Kendrick from Dynamic Tape. And this is myself, Lincoln Blandford, Head of Education with Comera Science. We're going to explore a little bit about some of the ideas about working with both the kinetic control approach, but also with Dynamic Tape as well. So it's great to see you both guys. So hello.
Oh, hi Lincoln, how you going?
Yeah, I'm good.
Good to see you again, Ryan.
Yeah, likewise, Mark.
So we've got quite an interesting link up today. I'm up in the UK, Mark's in Australia, and Ryan, you are in?
I'm in Vanuatu.
So you're out there in the Pacific Ocean.
That's correct. Those who don't know, so it's a small sort of island nation of 83 islands located between Fiji and the east coast of Australia, essentially. Yeah.
Fantastic.
So, for me. So.
Thanks for joining us today. So Ryan, over to yourself. Can you tell us just a little bit about sort of the history of Dynamic Tape and yeah, a little bit about sort of how it works essentially and how it's maybe different from other tapes?
Yeah, sorry, I just the Vanuatu internet connections getting to us there, but yeah. So, but basically the history. Look, Dynamic Tape's been going now for about 10 years, I guess. And originally we sort of never set out to start a tape company, but we were looking for solutions for our patients. You know, we were looking at how we could manage load on them. We knew that, you know, load was very important for both in the development of pathology, but also in the recovery. You know, we don't want to unload people completely. It's certainly not a popular option with our athletes and things either. But we wanted to get that functional stress through things, that early functional loading, perhaps post-operatively, so we would get nice repair process going and all those sorts of things. And at the same time, we also wanted to be able to allow full movement. Again, movement being really probably the biggest way that we dissipate load, obviously, is to move. But also, once again, for function, you know, to be able to get into complex tasks in our work or in our performance of our sport. And there really wasn't anything out there. We were doing things like taping TheraBand to people and you know, inner tubes from bicycle tires, anything we could do to try to get that external force on there to do the work, to take load off something that was overloaded, or perhaps to assist where something was weak. If somebody had poor inner range knee control and were collapsing into flexion, if you like, could we come in and do something externally there to provide that, to improve that movement pattern, to perhaps change their position. So I guess in a way we were looking at two things. Can we modify the kinetics directly? So can we just do some of the work if they are overloaded or if they're weak, to combat or to overcome the external forces on them, whether that was gravity acting on the body, a foot drop, or whatever the case may be. And secondly, could we then, if we could get this genuine forcing, could we then change the movement and the kinematics, which again has a knock-on effect on the ability to generate and transfer force by altering things like our length tension, where we're operating on our length tension curve, perhaps changing the lever arm, maybe it's our tibialis posterior, and by changing the resupinating a little bit, we're changing that orientation of our subtalar joint axis, increasing the length of the lever arm of tib post, and again, increasing the ability to generate and transfer force will make it more efficient. So, yeah, it was sort of what we were trying to do, I guess, in simple terms, like a dynamic splint. You know, we've got this big rubber band on there. Say somebody's had a flexor tendon repair. We've got the splint component and the rubber band component. They can use the active sort of intact extensors to allow gliding and movement and all the benefits of some low functional stress through it. But then the big rubber band would spring them back to do the work to protect the graft. And it was sort of a little bit, you know, that principle, but trying to apply it everywhere, and obviously without the limitations of the restriction of the splint or restriction of movement that we would get with an athletic tape and those sorts of things.
Okay, fantastic. So the idea then, both sort of changing both the kinetic and kinematics around loading using tape seems to be a sort of a key feature of what we're talking about. So again, just going to throw this open to Mark here. So Mark, in terms of the use of dynamic tape, how do you see that working with, I guess, the KC approach?
Okay. Yeah, so the so the Casey approach, has a couple of key components to it. It's looking at, the direction and the coordination of control of direction and at the site and direction, and also looking at the recruitment synergies between the muscles that provide movement or control movement or create restrictions. And so, one of the things I've certainly come across since I first came across dynamic tape, and Ryan, you did that course in Brisbane a while back, and one of the things I come across, it's simply one of the best products I've come across to work with, augment what we do. So I probably would use it on close to 80% of all the clients I see nowadays. So, and one of the things that I really find with it is that in terms of providing that proprioceptive feedback about, when we want people to control a particular site and direction, we can use rigid tape if they're really acute, but that really locks them up and they actually don't use the dynamic movement. So we can use it in terms of our site and direction control to get them to do low threshold and high threshold work. But it gives them the sensory proprioceptive feedback to provide augmentation of the cognitive control work we do. That provides physical support as well, because we can use a couple of different tensions in the tape. We can use the standard tape, we can use the eco tape, which is higher resistive tension. We can set up a power band to let you greater range of movement. So there's a lot of different ways that I use it personally for the site and direction control work. So to teach people how to coordinate their control of provocative movements in particular. But then the other component is that, that's sort of the early symptom management component. And one of the other things that I find really useful is in terms of the dealing with recurrence, is making the recruitment efficiencies work in terms of the muscles that have a global stabilizer role, having to work, being able to move your joints through your functional ranges of motion. And that's where sort of what Ryan was talking about, it can assist the muscle. But one of the things that we find in terms of our testing of these global stabilizer role muscles is that they often become posturally lengthened or inhibition lengthened. So they become inefficient in their shortened range. So we can use, because of the elastic potential of the dynamic tape, which we can't really get out of any other product I've come across, we can tension the muscle, we can position it into its shortened range. So we get sensory feedback about where that range is and how to use it. We get assistance to work into that range when people are inefficient there, but we still allow them to use the full range. And as they work eccentrically, they get a sensory stimulus and eccentric training component that they've got to work those same muscles too. So it gives us the eccentric outer range recruitment, it gives us inner range recruitment and support for the stabilizer role type muscles. And there's also a bit of work that's been done. And again, the science behind this is probably, so Ryan will be up a bit more on, but in trying to use taping to inhibit over recruitment of muscles as well. So for the mobilizer muscles that are over recruited, by taking some of the stimulus out of them, we might be able to inhibit them. So it works in both sides of our kinetic control system, for the earlier teaching and then facilitation of direction control training for the coordination of sight and direction, but then also for changing the recruitment synergies, particularly for the stabilizer recruitment patterns. And then we can use it to work with our low threshold, non-fatiguing functional loading, or we can use it in the background of resistance loading as well. So for high threshold stuff in the matrix. So yeah. So
I was just thinking on that. So hearing you talk about that. So in the early stage, I guess with our coordination type efficiency work, the sight and direction work, move this. Let's not see any observable movement at that, as it were. That sort of idea. We're offering that sort of additional proprioceptive input to the patient, the client. But I think even more interesting at the moment is what we're describing in terms of the synergist work, where when we're, it's almost sort of a pseudo synergist we're adding, or some sort of synergy augmenting process, because we're adding this additional component to a specific synergist in a specific vector that we're trying to sort of, again, augment one specific synergist, or again, this idea about inhibiting. So again, maybe the inhibitory type work, I'm going to sort of take that back to Ryan, actually. Ryan, any sort of ideas on this sort of inhibitory type idea that we've been talking about there?
Yeah, look, I think if you look at the basic physics of it, ultimately we're a body, quite literally, but we're being acted upon, and acting upon our environment. And we have to be able to transfer load to a racket to a ball and those sorts of things. And so, you know, at certain times, what we find is that, you know, say we have somebody post cruciate ligament reconstruction, you know, and they have, you know, inhibition of their quadriceps and poor ability to maintain that inner range quadriceps control, you know, and ultimately what we're looking at is that load acceptance phase, gravity acting on the mass of the body, and can they generate a significant or a sufficient extension moment at the knee to control that flexion moment that's being imposed on them. And the basic physics, it's basic, as you say, a vector summation there or vector addition. If we can apply a force, a genuine mechanical force externally, then we can basically complement or between what we have with our quads and what we have with the tape, we can then overcome that force. And there's some nice videos that we have actually of people who have had nerve injuries, so compression injuries or transection injuries of nerves where they actually don't have any real active movement, if you like, of the wrist extension, say in radial nerve. Actually, one was posted literally today, this morning on Facebook. And, you know, the person can't grasp or anything like that. With the tape on, as soon as they have it, the tape has sufficient resistance and then recoil so they can push through it with the active flexors, and then it opens their hand up and they can grasp and this sort of thing. So, and as Mark said, we can laminate multiple layers together to create what we call a power band. So we can be getting, you know, in the range of 15 kilograms or more of resistance when we're moving, particularly at speed, say on an Achilles tendon, resisting that dorsiflexion moment. So therefore doing some of the work of that overloaded, for example, Achilles. So to answer your question, I think in terms of inhibition, there are a couple of ways that we can approach it. One is if we can do the work externally, we reduce the workload requirements or the demands on the structure that would otherwise have to do it. So, for example, with the Achilles there, if there's no tape in place, the Achilles has to control 100% of that eccentric dorsiflexion as we land on the toe. If we have the tape put on in, as Mark said, a fully shortened position, so in plantar flexion with tension, such that as they go into dorsiflexion, it's going to be resisting that movement, then basically the calf now has to do, you know, no longer has to do 100% of the work. Its work is reduced by the amount of work that the tape can provide. The other way, I think there's probably two other ways that we can reduce work of muscle from a mechanical perspective. And one is by improving efficiency. So like we said earlier with the tibialis posterior, by changes in position, we can alter a couple of other things. One is that we can alter the length of a lever arm, for example, and that might be the lever arm of a muscle. So obviously if the insertion, if the distance where the force is applied is further away from the axis, we have a longer lever arm, and therefore for the same amount of force or work of muscle, we get increased torque production. Okay, and we do know around the foot, if we supinate more, it actually increases the distance that tibialis posterior insertion is from that axis. And so therefore, to produce the same force to counter the pronation moment, tib post doesn't have to work as hard. So that's reducing or effectively inhibiting a muscle that tends to be overactive because it's inefficient at generating the force. The other thing is if we look at, say, something like a shoulder, you know, again, if we're in an anteriorly rotated, anteriorly tilted, downwardly rotated type of position, we have a few things going on, you know, where we can come in and take the weight of the arm and upwardly rotate and bring them back. And what we're doing there are several things at once. One is if we're in that downwardly rotated position, those upward rotators, our middle and lower fibers, the trapezius and so on, tend to be elongated. So they're at length and therefore in an inefficient position to generate force themselves. So actually by bringing them back into a better position, we can better recruit those. And in doing so, we can then get that reciprocal inhibition, if you like, of some of those overactive downward rotators. So it's not that we're, you know, putting a tape over a muscle to try to get some neurophysiological inhibition. I think the jury is sort of a little bit out on how that works. You know, certainly some of the things that we thought worked have probably been shown to be a little bit different to how we understood it. Certainly, Dr. Caroline Alexander out of the UK and their colleagues have done a number of studies looking at taping across muscles and along the line of muscle, and the idea with lower facilitation, and if we taped across the muscle, maybe levator scapulae or something like that, we would get inhibition. And they looked at your Hoffman reflex, so your motor neuron pool excitability basically, and they showed actually that taping along lower trapezius created inhibition rather than facilitation from a motor neuron pool level. And taping across it didn't do anything. And then they repeated that on the calf and they found the same thing. Now, they were in asymptomatic people. We don't know if people in pain behave the same way as people who aren't in pain. We don't know if certain muscle groups, because we know muscles have different roles, so we don't know if certain muscle groups behave differently or not. So there's a lot of unknowns around some of that in terms of the neurophysiological side of it. But in terms of the loading side, we know that load, as I say, is a key driver. We know that we can influence the work of muscle internally. And some of the nice research to taping in the shortened position with tension. So we have exactly the same skin contact. We have the same appearance of the technique. So from an expectation point of view, we would, we sort of account for that. And what we're seeing on the studies that have done that is that the effect is far greater in the ones that are taped in the short position with tension. So that's sort of suggesting that, yes, we are getting a mechanical effect. And when you have it on, you certainly can feel that it's a mechanical, the mechanical resistance and assistance immediately.
Yeah.
So the idea that sort of the load share and demand share is something we've played with a lot, certainly in the last few years. And we've sort of applied it to specific sort of tissues at risk, I guess we describe it. We've done some work on the hamstrings, for example, how we might look after a bicep femoris long head by sharing the work out into other synergists. We've also been thinking about doing the same thing for something like a soleus, and we can just take it to any of the different structures that often are problematic. So this has given us another option to do that sort of demand share, load share type approach. We can be very specific with how we do it as well. I think sometimes with the muscle synergy approach, it's a little bit hit and miss depending on who we're working with, that as best we try to deliver our retraining interventions, sometimes the individual, the patient, the client just doesn't get it. So this is a very nice additional way that we can sort of tick the boxes with more chance of getting what we want from it. So again, Mark, I'm going to come back for you. Again, any additional thoughts on any of that, really?
Yeah, I think one of the things that we really find beneficial is that with the way that we look, is we try to put a diagnostic criteria or a diagnostic framework to the site and the direction of our coordination alignment issues. And so by using that as a framework to choose what additional taping I might use, so just because something hurts doesn't mean it's always going to respond well to taping. So by having a diagnostic framework to choose what site and what direction I might want to look to control, and then how much I want to control it. So in some situations, I would still use rigid tape to absolutely stop it from moving because it's just too acute. But that would be a very short window, and it's not very functional. So that's sort of the uber protection phase. And I want to get people out of that in getting them recovering movement as soon as I can too. So that's where sort of, we can use sort of, an elasticized dynamic tape to provide a really good sensory control mechanism there. And then, but because, some people with, for example, a shoulder problem their sight and direction of uncontrolled, but it might be downward rotation. Someone else, it might be forward tilt. Someone else, it might be humeral anterior glide. So all those people are going to present with pain in the anterior shoulder. But by having a clear diagnosis of the movement control fault, or the movement control impairment, or the alignment coordination, movement choices that they've lost, we can give that framework, and that then can make me very specifically pick a taping that's going to, number one, help their symptom control, but also help their movement control recovery. And so that whole combination is what I find particularly useful, is having a diagnostic framework to help me choose what particularly I'm going to control when I'm using sight and direction control taping. And then based on that, I can then work out which muscles I'm going to need to facilitate into more shortened range more effectively in terms of the stabilizer, mobilizer in the global stabilizer role, global mobilizer role synergies, to try and really facilitate that long-term recovery. Because that's one of the things I find makes the biggest difference to recurrence, is getting that, not just symptom management, because the symptoms come back, but what changes recurrence is changing the efficiency of how they move through the full range. And then so basically in terms of the muscles that I want to facilitate in terms of recruitment efficiency, and from the kinetic control framework, I would do a test of a variety of different synergists. And the ones that fail their recruitment efficiency in shortened range, the inner range hold recruitment efficiency tests, they're the ones I'm going to particularly use facilitatory taping on, rather than just everything, And so what it gives is, what it gives me is a clinical reasoning framework around not just, because I'll choose the tape, and the dynamic tape gives me movement along with the tape rather than just rigidity and just uber protection. But what I've got is a clinical reasoning framework about how to choose which taping technique I might use to control which site and direction, and then also which muscles I specifically want to facilitate or inhibit. Because I've got a test that tells me there's the problem there.
So Mark,
I think.
Sorry, Ryan, over to you.
Sorry, Lincoln. Can I just jump in really quickly, because I think that's one of the things, people come from different backgrounds, have different areas of expertise, but that's certainly one of the things that we find, because you certainly see that a lot of people want to tape by numbers. They want this recipe cookbook approach that, for this condition, I'm going to tape in this way. And as Mark said, you can have several people with anterior shoulder pain and tape them all differently. And we certainly, our approach is to, number one is that, having a clear aim is 100% or 95% of the technique development. And that comes back to having identified a very clear deficit. What is the deficit that you're trying to address? And the deficit isn't a diagnosis, it isn't a structure, it's going back that step, which I think is what the kinetic control side of things gives people a nice framework on how to do it and how to assess for that. And it's not only then what is the deficit, but then what's the relationship between that deficit and the problem that you're trying to address? And then obviously you need to have observed that on particular patients. So we can't just take the research and say, oh, well, look, people collapsing into hip adduction, internal rotation, is associated with their greater trochanteric pain syndrome. But the person presenting in front of you may not be exhibiting that. Not everybody in the research, studies all present the same way. And so it's not only, identifying the deficit, but also how that relates to the person that you're seeing in front of you. And then by what mechanism can the tape actually address that? Is it that we're just introducing a force into the system? Are we changing the kinematics and addressing some of those other things like length, tension, and so on? Are we creating compression and maybe enhancing that force closure mechanism by increasing the stability and that coefficient of friction at the joint surfaces, maybe on a syndesmosis injury or something like that? And then how do we go back and evaluate to determine that we were effective in that way? Because as I say, the tape is very effective, and the research is showing this at changing movement. And we might change that person with hip adduction, internal rotation, and it may not change their pain with trochanteric pain syndrome. Now, that doesn't mean that the tape did its job, because its job was to take some of that load, reduce the magnitude and velocity of their collapse into hip adduction, internal rotation. But what it means then, we can use that in our reassessment and in our hypothesis to sort of say, well, look, clearly in this person, either we need to increase the magnitude of the amount of work that we're doing, or that perhaps that movement in that particular person isn't associated with their condition. And so it helps us build on our hypothesis as well.
Yeah, well, but just along that point, that I think is a very important point, Ryan, is just putting something on generic by numbers. I've got this condition, I use this tape. Often doesn't work. We all see that, historically in the past, and that's why one of the things I find particularly useful is I can put the tape on for the particular goal or the aim I'm trying to achieve, but then I can redo the test that told me I've got a deficit, and so show that, number one, it's better with the tape on, so they're going to then create learning and improve functional efficiency while the tape's on, and they're going to take stress away from provocative tissues while the tape's on. But number two, I can then reevaluate when the tape is off. After they take the tape off, when I'm looking at it again, have they taken a step forward in maintaining a better level of control? Are they able to maintain a pass of that test? Or, have they improved but not fully there yet? So part of that that's a really important part of clinical reasoning, clinical framework. We've got to come with a diagnosis. We've got to provide an appropriate intervention, and whether we use taping or whether we're using movement control or combinations of that cognitive exercise and movement control, they all work great together. But then we want to reassess the effectiveness of with the tape on, and has that created a learning response? Has that created a structural response over time that then we don't need to use it forever, you know?
Okay, guys,
Correct. And it can give great buy-in from your patient too, because they see, you know, they can see the effect that you've had, and therefore that helps with your compliance with their exercise and everything else.
So important, yeah.
You know, so there's all those things, not to mention things like, you know, beliefs around self-efficacy and, oh, look, you've changed my pain immediately, so I'm not going to be stuck with it for the rest of my life, and things like this when you start getting into some of your more persistent pain cases. So there's a lot of additional things, if you like, beyond just taking some load and changing some movement.
Yeah.
Okay, guys, so I think one of the key points that come out of this is the framework of KC, but also then sort of really strategically applying dynamic tape within that framework as well, and using both to maximize the opportunities provided by the framework and also the tool itself, and really sort of using some good clinical reasoning to how you apply it. Any final thoughts before we sort of round up for today?
Yeah, just one. Because the time that I've actually done this only in a course environment for clinicians was in New York last year, before the virus hit us all. But that was incredibly successful. The therapists who'd been on that course were people who already had the concept of our diagnostic frameworks and our testing, and then they, you know, like what they found is that this was just such a great tool to work with what we do, you know. And so, you know, because the bottom line is we want people to change the way they move, and and using a cognitive retraining program based on the clinical diagnosis, plus also then supporting that with a taping strategy that can deal with more than one goal in what we're trying to achieve, and we can use it as part of reassessing the effectiveness of how we change movement for the better.
Yeah, it's like having Mark walk around providing some tactile feedback and some verbal cueing the whole time, you know, 24 hours a day. So, but look, I agree as well, because as I said, one of the big issues that we have certainly in some countries is people don't have that foundation of the clinical reasoning of their anatomy and biomechanics and so on. And you know, the work that I've done with Mark and some of our instructors, for example, in Sweden, Claire, you know, Martin, a kinetic control, you know, instructors as well, and people like James Moore as well, you know, very big on the biomechanics. And so what we find is that it really does give people the basis to build their techniques from, and to develop that very clear aim to identify those deficits and the relationship, and then to develop a technique to address it.
Yeah.
Okay, guys, thank you very much. That's excellent. So real good insight in terms of using dynamic tape alongside also the KC approaches, the framework, the ways of testing and retraining movement. So thanks for joining us today. We'll say goodbye for now. So see you later, Mark.
Okay, thanks, Lincoln. Good to catch up with again, Ryan. And you know, we've got to start doing a bit more work together. It's a good idea.
Yeah, thank you both. I really enjoyed the chat.
Okay, catch you later.